I assure you tonight that Tim is going to sort of open the shutters and give you a lot of information. It's now on the forefront of a lot of practices' mind that they can do the Mandibular Advancements Splints, especially, and Tim's going to give you some of the prerequisites before you dive into this. And so, welcome, Tim. Thanks very much.
Thanks, Alex. Okay. So thank you for coming. Tonight, what I've basically done is we've broken it down into two parts. So I think we've got a second presentation next month. So the first part was basically reception of records, and then the second part next month will be more on the clinical side of actually making an appliance and delivering the appliance to the patient with the follow-up. So really, although it's a little bit dry, feel free to ask questions as we go along. And it's really more about giving you a good overview as to what we need to do before we even think about making a Mandibular Advancement Splint for a patient. Which I'll deal with this so there are different protocols and different rules that have been set out for using oral appliance therapy for sleep disorder breathing. And it hasn't been overly well coordinated, probably in the last 5 years it's tightened up somewhat, and there are different bodies with different guidelines, and it can be quite confusing for clinicians choosing to get into sleep disorder breathing as to what rules do we follow, and who do I answer to, who are the governing bodies. So the Australasian Sleep Association have a very good website, which I recommend any of you who have got an interest in this field. They've got some wonderful information on the website, and they provide this template here. And this template was established probably maybe 6 or 7 years ago. But essentially, the main thing with oral appliance therapy, when I talk about oral appliance therapy, by default I'll be talking about a Mandibular Advancement Splint, because that's the main appliance that we use. But essentially, these appliances are medically indicated, they're not dentally indicated, and that's really the key thing I want you to get from tonight. So, whilst as dentists we're licensed to provide oral appliances for dental conditions, we're not licensed to provide oral appliances for medical conditions. These appliances must be prescribed by a suitably qualified specialist physician. And it's important that when we undertake treatment, we very much are clear on that. In the past, there was a situation where dentists could just take records and make an appliance if the patient came and complained of snoring and the like, without any jurisdiction, without any requirement, without even to get a sleep study. And the problem that came of this, of course, was that with sleep apnea, we understand that you can have the condition and not snore, and you can snore and not have the condition. The biggest problem with oral appliance therapy, particularly Mandibular Advancement Splints, is they are potent at managing snoring, but they're not nearly so good at managing apnea. And a lot of patients automatically thought that once we had snoring under control, then the apnea was automatically managed at the same time. We now know that's not the case, and of course we were seeing patients that were having those appliances made, only then to find that the underlying apnea had not been addressed and the patients were presenting with other medical complications, heart attacks, strokes, you name it. So that's why things are tightened up. And the ASA have really sort of defined it quite clearly for dentists. Really our role is once we've got that instruction, we have some requirements that we need to do when we assess the patients, medically and dentally. And it's important to understand that you need to look at the patient globally. We need to be looking at their jaw joints, we need to be looking at their muscles, we need to be looking at their teeth, not just focusing on the oral cavity. Most of these patients will have some level of T&D. It's fairly rare for them not. And what I'd also say, if you are interested in this field as well, you need to develop the skills in the management of T&D, certainly in the diagnosis of T&D. And it goes on. really the other aspect with managing these patients is we need very clear written communication. So, and we're not communicating just with the patient, but we've got to communicate with the physician, with the GP, with the dentist, with the patient, and you've got to keep very, very good paper records. So your record keeping needs to be impeccable. A situation there might be if you had a patient who had severe apnea who didn't respond to CPAP, or the word they use is refractory to CPAP, so they might prove to be intolerant or they decline CPAP, then these patients are then deemed to be okay, something's better than nothing, we'll use a Mandibular Advancement Splint. On a prescription, you make the appliance, but then the patient doesn't return for follow-up. Now, if that patient's got severe apnea, it's a notifiable condition, and it is something that should be on a driver's licence. It's no different than epilepsy. So if this patient doesn't show for a review, and the referring specialist is not made aware of that, this is where they just slip through the cracks. So written communication is absolutely paramount for patients that do present, and more so for the patients who don't. Then the American Academy of Sleep Medicine really started to instigate a lot of the foundation for dental sleep medicine. And it sort of began, the first guidelines began in about 1995. And really at that stage, oral appliance therapy was for primary snoring. So primary snoring is snoring where there is no adverse effect on ventilation. So there's no upper airway resistance, there's no hypopnea, which is a 30% reduction in ventilation for more than 10 seconds, and there's no apnea where there is cessation of ventilation for more than 10 seconds. And at that stage, really, the oral appliance therapy was deemed for the primary snoring and the mild cases. The moderate and the severe were more in the category for CPAP or PAP, positive airway pressure. The other situation that came of it was that they didn't see the need for a follow-up sleep study with mild OSA. It was only deemed necessary for moderate to severe. And again, the reason why we have follow-up sleep studies for oral appliance therapy is because we have no way of predicting or knowing who's going to respond to this treatment. It's not like CPAP where we have a reader on a machine, or we can download information to a cloud and access that. So we do not have that tool with oral appliance therapy. We cannot tell who will respond and who won't until we have a follow-up sleep study. Then in 2006, when they started to do some homework on the mild cases, they started to realise that we could have cases where they might have severe apnea, so an AHI more than 30 overall, and not be symptomatic. No symptoms, just found just by chance on a routine medical examination. It might be for a truck driving licence or working in a mine or whatever. And then we can have patients who have mild apnea. They might have an AHI of 6 or 7, and yet be very, very symptomatic. So with this, and also they found with those mild cases that their risk profile, their medical risk profile, was sometimes no different than a patient who was severe. So just because you're mild, sometimes it doesn't always dilute your risk profile for medical events. So with this, they then felt that really, probably what we should be looking at is we should be probably looking at follow-up sleep studies for all our patients. And that's really what came out of the research, and Ferguson was the person who did most of the work on that. In 2013, as this began to evolve, then we had the American Academy of Dental Sleep Medicine. And this was an arm of the American Academy of Sleep Medicine. And they too have a very good website. And you can draw down a lot of information that's quite useful. They then provide these guidelines. Again, we're starting to tighten up on what we consider to be appropriate guidelines for managing patients. And what was starting to come through in this era was the need for dentists with recognised training. Dentists who had undertaken a certain level of training and who were proficient with overall management of patients with sleep disordered breathing. They were starting to realise that, you know what, this is a more complicated field than what we originally thought. in 2015, this article, and you'll see reference to this in the ADA Dental Glossary. So if you look up code 984, and the glossary to me is like MIMS, I look at it routinely to look at the definition of codes to make sure that what I'm billing is consistent with the definition within the glossary, because that's what we're bound by. And within the glossary, they make reference to this article, and it was published in 2015. And quite frankly, it's a bit of a toothless tiger. I'm not too sure why they draw reference to this article. But basically what it was just a sort of an update where they had this task force, and they go through and review all the literature. And we work out, are our current guidelines up to speed? And they sort of drew these generic guidelines, not so specific for the provision of the appliance itself, but more generically, that I think what they're probably doing is more having a dig at sleep physicians, because a lot of sleep physicians, not all, but I'd say at least 50%, would routinely not advocate mandibular advancement splint therapy as a treatment modality for mild to moderate cases. A lot of these cases will automatically get spun onto CPAP. And the reason why they do this is because it's evidence-based. We understand that CPAP will treat all levels, so all severities of sleep disorder breathing, almost immediately. And we can verify this with a reader. And that's why it's the gold standard. So I certainly support sleep physicians on that, but at the same token, if we do get patients who don't want CPAP, are not good candidates for CPAP, they might travel a lot or work away, then these patients should at least be given the option of oral appliance therapy as a fallback or salvage position, rather than not prescribe it at all. And this was sort of really what this article was about. The relevance of it in the glossary, I don't really understand. I'll come to the article that I think is probably more relevant in that. This article here is the one that probably helped gel it all for me. So when I did my program, this article by Epstein et al. In 2009 is a brilliant article. And it would probably be the key seminal article that would link and bring together all aspects of management for sleep disorder breathing. So not just on oral appliance therapy, but all aspects, from behavioural therapy right the way through to surgery. And it puts things in perspective. It sort of gives you that tree trunk that you can stick your branches on. And this is an article I'd recommend to anyone. The main thing that Epstein started to draw on here, that was before we initiate treatment, we've got to have a diagnosis. And it's something that we probably are all at fault of doing in any aspect of our work, is often it's easy to begin treatment without a diagnosis. We think this is what's going on, and we provide a treatment and then it doesn't work. Or we provide treatment and we get complications. And it's largely because we didn't get adequate diagnostic information to begin with. So we need a good diagnostic tree. And the protocol here is largely performed by a respiratory sleep physician. And I'll come about how we get to that space in a minute. So with this, when a patient arrives at a respiratory sleep physician, the first thing that they will receive is a number of questionnaires that they fill out and then they have to bring with them to their consultation. Then the respiratory sleep physician will perform a physical examination. What has happened with a lot of improvement over the last 5 years, I'll stand here so I can see a little better, is traditionally the respiratory sleep physician would look at questionnaires, but he would not scope the patient with an endoscope. So, in other words, a sleep study provides a diagnosis. We have sleep apnea. It will quantify the severity of the sleep apnea, mild, moderate or severe, but what it doesn't do is it doesn't identify where that obstruction lies. And the obstruction is really key to success with treatment. So is that obstruction at the nasal level, is it at the palatal level, is it at the tongue base level? Because that's going to determine what treatment will be largely successful. In simple terms, as the severity of the apnea increases, the level of obstruction becomes more multi-level. And hence, we generally find oral appliance less predictable. Oral appliance therapy is really good at tongue base level and maybe at palatal level, but it's not too good at the level of the epiglottis, and it's not too good at the back of the nose. So now what's happening with the sleep physicians that I work with, and people say, who do you use? North of the river, I use Jack Philpott routinely. He's excellent, Jack Philpott, and he's over at Hollywood, and Jack has lectured to groups and given up his time. And in the southern corridor, I use Seneca Honey, seen us down in Leaming. And both of these sleep physicians will now scope their patients. Traditionally, this was in the realm of an ear, nose and throat doctor. So in the past, we get the diagnosis, the patient might be slapped on a CPAP, but then of course this treatment was not successful, or the patient couldn't cope with it, and then they'd say, okay, go and try an oral appliance. And we'd make an oral appliance, and that too wasn't all that good. And the reason for it is because we have determined where the obstruction was. If these patients have a nasal obstruction, neither of these treatments will be effective. So now these sleep physicians will scope the patient. If they do see significant nasal obstruction, they will be recommending, or at least tabling, the notion of having facilitatory nasal surgery prior to undertaking CPAP and or oral appliance therapy. The only caveat for that would be someone with very severe sleep apnea, or someone who's symptomatic, or are at risk driving a vehicle, or need to operate machinery in a workplace. Those patients will be required to be CPAP compliant up until surgery. But the beauty with managing nasal obstruction early is you could then use a lower pressure on CPAP, you could use a smaller interface on CPAP, and or an oral appliance is going to be so much easier for the patient to tolerate. So nasal patency is key when it comes to success with any of these treatments. So now once we've scoped the patient, they'll then determine what sort of sleep study we use. Broadly speaking, there's 4 types of sleep study. 1 is comprehensive, attended. 2 is comprehensive, unattended. 3 and 4 are portable. And really the lion's share of the work now is type 1. We're finding that it is probably more cost effective to have a type 1 sleep study where it's attended, and if something falls off, the technician can come back in and put it back on, and the detail with the reports a lot more accurate than if someone is sent home, and if the study is suboptimal, the patient has to go through a type 1 regardless. Then, once we have all that information before us, the sleep physician then gets the patient back and goes through the results. No different than what you and I do when we manage a patient. If there's any level of complexity, they'll have a review consult prior to any treatment being advocated. So the main issue here, or the key point, is only the respiratory sleep physician can provide the diagnosis. And we must have a diagnosis before we can commence treatment. Once we have that diagnosis, then there are other people who can recommend oral appliance therapy. And broadly speaking, that might be an ear, nose and throat physician. That's a common portal of call. You might get a referral from an ear, nose and throat physician. I suspect this patient has sleep apnea, please make a Mandibular Advancements Splint. Well, the first question is, where's the sleep study? Do I have a diagnosis? And on that sleep study, does it specify that this patient is a candidate for a Mandibular Advancement Splint? So that diagnosis and that prescription must be there regardless. And that's very important. If you don't have that in writing, do not commence any further. When it came to this diagnosis, of course, what tightened up significantly last year was Medicare did a big investigation into what was perceived to be rorting of Medicare with unnecessary sleep studies. And I think it's fair to say a lot of sleep studies were unnecessary. And the reason for this being because patients would present to the GP and saying, I'm tired and I don't feel well, my sleep's not refreshing, and he'll say, you know what, let's go and get a sleep study. And they'll routinely prescribe just a home-based sleep study. It still has to be funded by Medicare. But what we understand is there's many things that can make us feel tired. So the most common thing that will make us feel tired, if I'm female, might be anemia. Or it could be hypothyroidism. Or it could be uremia. You could also feel tired if you have been doing a lot of shift work. Or if you have moved to a new location. Or if you have moved into a new house. There's lots of things that can cause us to be tired. It doesn't have to be sleep disordered breathing, and we don't need a sleep study to tell us that. So this is where Medicare decided, right, we're going to tighten up. So now, if I get a patient that I suspect might have sleep disordered breathing, I do my little one-page summary, I send it to the patient, it's a summary of the medical findings and what I suspect is going on, and doctor, I've asked the patient to seek your advice regarding the benefits of sleep study, question mark. So I'm not ramming it down their throat. I'm just politely saying, hey, you're the doctor, I'm not, but I reckon this is what might be going on. Now what has to happen is the GP has to get the patient to fill out 3 questionnaires. You've got to do what's called an OSA 50, an Epworth Sleepiness Score, and a stop bang. And the patient has to tick off greater than that on 3 of those questionnaires, all 3, before that GP can refer them on for a sleep study. Otherwise, that patient must be referred to a respiratory sleep physician. So that's the thing that has changed since November last year. I think it's a positive step, because once patients do see a sleep physician, the sleep physician can triage this. And in many cases, a patient who has insomnia doesn't need a sleep study. And a good sleep physician will be able to get all of this from their medical history. So this is then when we come to this glossary and we say, right, we're going to use this code, we need to understand the definition of it. But I've highlighted there, it is on the request from a specialist physician. It is not on the request from a GP. And it is not on the request of another patient or another dentist. It's a specialist physician. So now, what do we deem to be the indications for using oral appliance therapy for sleep disordered breathing? Primary snoring, so we've got snoring, but we don't have any other adverse respiratory events. These patients don't experience a lot of sleep arousal or any sleep arousal because of their breathing event. Upper airway resistance is more common in women than men, and premenopausal. So the reason for this is women are different to men. Why is that, Alex? Correct. So women are made to breathe for 2 or more at once. Males aren't. And so the key difference here is progesterone. And progesterone is key at maintaining airway. So when women become perimenopausal or menopause, there's no more eggs, the brain says, well, we don't need to maintain the airway so much now. And that's why the profile of sleep disordered breathing starts to equate to that of a male post-menopause. Pre-menopause, it's half the risk for women. Post-menopause, it's equivalent risk, male, female. So that also is a red flag for me. I get a lot of women coming with symptoms, TMD, all these sorts of things. You know, menopause, when did it happen? Right, is that a red flag? Has that changed the balance? Could this patient now have some level of significant sleep disordered breathing? Where now we've started to move into the grounds of full obstruction or greater than 30% reduction in ventilation, so the hypopneas and the apneas. Upper airway resistance, we just have the arousals. A lot of these patients suffer from insomnia, maintenance insomnia, particularly in the second half of the night with REM, because the brain says, I don't want to go into REM sleep, because that's when my muscles all go floppy. So a lot of these women will wake in the middle of the night and find it very, very hard to go back to bed. So when it comes to the treatment tree, the first thing always with management is behavioural therapy. And it's crucial. And we understand with weight loss that a 10% increase or decrease in weight will equate to roughly a 30% increase or decrease in the severity of your apnea. So weight loss is key. What's the problem with weight loss is most patients with sleep apnea develop dysfunction with leptin and radon our appetite hormones, and these poor people don't get satisfaction from the same amount of food. So they tend to eat a lot more food. They might wake in the middle of the night and eat a lot of food. And so they put weight on. So it's not so easy telling a patient, you're fat, lose weight. And that's not our job either. That's a medical environment in my book. Our job as dentists is not to sort of rule patients on their weight. That's a medical domain. Leave that up to their doctor. So these are just classic things that we understand that we can do at a behavioural level to try to lessen the severity of apnea. And that is the first thing. It doesn't matter what level of apnea you've got. We must always start with behavioural therapy. And for me, yes, I've got a level of sleep apnea. And the first thing that I did, and probably the most profound thing I did, was I discontinued drinking alcohol sleeps before work. So just 1 centimetre of even a low strength drink within 2 hours of bed is enough to reduce pharyngeal tone to double the severity of your apnea. And that's why we all snore more when we've had a few grogs. So for me, I never used to have lunch because I'd always get tired in the afternoon. So I'd never have lunch just to keep going, get through a day. But cutting out alcohol sleeps before work makes a big, big difference. Massive difference. And of course, touching on testosterone there, we understand too for males, a red flag is that if we do see males taking testosterone supplements, that's a bit of a red flag for sleep disorder breathing. A lot of males will become low in testosterone, so the doctors will then give them a supplement to make up for it without thinking, why is this patient low in testosterone? So when males start to develop apnea, usually severe apnea, moderate to severe, in some cases we'll start to dump testosterone because testosterone makes our airway floppy. It's the way of the brain looking after the body. And then the doctors in their wisdom prescribe us testosterone and let's have some benzos while you're at it to help you get to sleep. And of course benzos will also make our airway floppy. This makes everything worse. Positive airway pressure, put simply, 100% effective almost immediately. It is the gold standard without question. What's the problem? Compliance. People don't want it, or people sometimes really struggle with using it. So then comes oral appliance therapy, and really, the main thing here to understand is whilst there are all these different appliances out there, there is no one appliance that is any better than any other. There are some key criteria which I'll touch on tonight, but the key thing is don't be swept up with all the hype and all the advertising and all of this stuff that you can see and read. A lot of it does not have any basis. The main reason why oral appliance therapy is not indicated for severe, simply put, is because one, it's not predictable, and B, it takes time for these patients to get up and going on an oral appliance. In my hands, it might take, it might take a good couple of months before they're up wearing it 5 nights minimum and waking with it. If they've got severe apnea, of course, what we're worrying about is all those nights that they're not wearing it or keeping it in and they're desaturated. And that, of course, is the risk. So we have all of these things, but don't be fooled by any of them. You've got to understand how the appliance works and the key features I'll talk about in a minute, and then you apply that. This appliance has got those, I'm going to use that appliance. Surgery, I won't dwell on that, it's used as a salvage position, other than facilitatory nasal surgery. So facilitatory nasal surgery, again, is where a patient might have, what would be the most common group of sports people to suffer from apnea as they get older, Sam?
Boxers, weightlifters.
Good, Sam. It's actually rugby, but yeah, boxers. Broken noses, right? They have the highest risk. So these people need to be earning lots of money when they're young, because as they get older, they're going to start to pay a price. They just don't know it yet. So surgery is always a salvage position. Why? Because one, it's not predictable. We can't predict with surgery who will have a positive outcome and who will have a negative outcome. And a simple rule is maybe 80% of patients might get some benefit, 10% will get no improvement, and 10% get worse. But what we do understand is we don't use laser anymore. That's dreadful. That used to cause a lot of scarring. It would actually make the apnea worse. And then There are other tools. A very, very simple tool that can help patients with their apnea is an antidepressant because it suppresses the amount of REM sleep. So a common one is you might get patients coming in who might be clenching and grinding their teeth a lot, they might be snoring a lot, and the first question I say is, has there been any change in your medical history in the last 6 months? Have you been on any medications that have changed, stopped, start, increased, whatever? Oh, I was on some antidepressants, but I've stopped taking those now. Red flag. When they come off their antidepressants, I'm going to start pushing into REM sleep more. With more REM sleep, more muscle relaxation, we know the severity of the apnea increases. And so this is what you start to look for. The secret is the medical history of the patient. But put simply, there's probably, by definition, no pharmacological therapy alone that can manage apnea. It's a multidisciplinary condition and it requires a multidisciplinary approach. So how do oral appliances work? Put simply, 2 roles, mechanical and muscular. So the mechanical role is it pulls the tongue base forward as the mandible is advanced against the maxilla. And in the process through the palatopharyngeus, it will tighten the palate laterally. So it tightens the palate, pulls the tongue base forward, and it widens the airway laterally. And this then reduces collapse, or what we call compliance. There is also an indirect role where we find that we get increased muscle activity. It seems to stimulate the genioglossus. And by stimulating the genioglossus, which is the biggest muscle controlling airway in the body, this helps to also maintain the airway. So a simple analogy there for me is that if I'm working on a lower back molar, even if I'm cleaning back molars, and there's a tongue, and often these patients might be, they don't like things in their mouth, they might have big tongues, they might have an elevated gag reflex. If you find yourself struggling a little bit, just get the patient to hold their breath. And when they hold their breath, you'll just see the tongue just drop down. As soon as we start breathing, the genioglossus, the tongue, comes up and forward. It's a simple little test. But it's also a good tool when we work. So we must have the referral in writing. It must stipulate a Mandibular Advancement Splint. And it must come from a respiratory sleep physician backed and supported by a sleep study that's current. And a current sleep study in my book is less than 3 years old. I'll touch on that in a minute, or down here. The key difference there would be what might change the parameter with currency of the sleep study. It might be if the patient has put on a lot of weight. If they've lost weight too, we understand that could reduce the AHI by 30% or increase. So we need to look at their weight. Have you lost weight? Have you put weight on? These are the questions you need to ask in medical history. And you're asking the question for a reason. And is there any significant changes in the medical status? So again, the thing I'm looking for there might be even their medications. Antidepressants, things like this, benzodiazepines, all these little things that we know can impact on sleep. What I then do is I always summarise the sleep study. Because when you get these sleep studies, you've got all these figures and you've got to try and see the wood from the trees. I don't focus on the AHI. What I focus on, first of all, is I like to look at, I tend to go, when I have a little chart, and I'll certainly have my average, my AHI, but then what I'll also do is I will record the oxygen desaturation index, which is the number of times the oxygen drops more than, well, it depends who you listen to, but 3% from baseline. This is a reflection as to, whilst I can have, for example, an AHI of 10, that will be scored if I get 10 events per hour for more than 10 seconds, be that 11 seconds, 12 seconds, or 50 seconds. I could also have an AHI of 10 where, and that patient, that first patient who might have an event duration of say, let's say 15 seconds, they're scored, but the problem with that is that, or the advantage with that, is their oxygen doesn't get a chance to drop as much. Compared to a patient who might have the same AHI, but their events are going for 40 seconds, or 50 seconds, or 60 seconds. Their oxygen's going to really slide. So these are the ones who will record an increased frequency of oxygen desaturations per hour, that's what we call the index. And of course, they're going to have the lowest recorded oxygen, or what we call the nadir oxygen level. So we need to look at that. Just don't look at the AHI. Look at how long the events are, and by default, that's interpreted by your ODI and your nadir oxygen. Because I'm going to treat that patient who has very long events very differently than the patient with short events. And so too with a sleep doctor. So I received a patient today who had an AHI of 57, couldn't tolerate CPAP, but the sleep doctor said, you know what, let's make this patient an Mandibular Advancements Splint. Why? Because her events were on average only 16, 17 seconds. So this is where you've got to look at the devil. We also understand the arousal index. The arousal index is in response to these events, but they can also be caused by lots of other things. They can be caused by stress, by pain, by reflux, by limb disorders, periodic limb movement in sleep, and of course this is what's causing the clenching and groaning. So just because the patient's bruxing, it doesn't mean it's all to do with airway. It's usually multifactorial. The main thing that I look for in a sleep study, and I've highlighted it in red here, is that what will dilute or subdue that result? What will make that sleep study inaccurate? It will be a reduced sleep efficiency, meaning the amount of time a patient is allowed to go to sleep, or should I say the amount of time the patient sleeps divided by the amount of time the patient is allowed to go to sleep. So anything that waters down the duration of recording is also going to water down the accuracy of my measures. So sleep efficiency, a reduction in sleep efficiency will water down the accuracy of that sleep study. If that patient doesn't have any REM, or a reduced amount of REM, we understand sleep apnea is always worse than REM, that's going to dilute or subdue the results. And also if there's no supine recording, because we also understand that sleep disorder breathing is always worse than supine. So just because you get the letter saying, make this patient a Mandibular Advancements Splint, sometimes these sleep doctors don't look at the detail. And just because you've got that instruction, it doesn't mean you comply with it. So on occasion I will say, you know what, I'm not making you one because, you know, my gut feeling is I don't think it's going to work out, and my gut feeling with it is you could go to all the trouble and all the expense and not be better off. And sometimes I'll write back to the sleep doctor and say, I don't think this patient's a good candidate for these reasons. And sometimes I never get a patient from that doctor ever again. Do I care? No. Because I want to work with doctors who do analyse the sleep study before they make that referral. So, what are the key differences here? Really compared to CPAP, the problem with oral appliance therapy is it's not a predictable treatment. And predictability, in simple terms, is efficacy, which is how well that treatment performs when it's in the mouth, times or multiplied by all the factors that can influence patient response. And this is where we have responders and non-responders. Now, we know there are more factors that can influence patient response with oral appliance therapy than there is with CPAP. CPAP, I've just got to turn the pressure up and stick on a bigger mask to tighten the strap. But an oral appliance therapy is not that easy. There are many, many variables that will influence how that works. I'm not standing in your way there, am I? No. The other problem with it takes longer to titrate. That's why we don't use it on the severe cases. CPAP always straight off because it might take several months before we find that sweet spot. Some people used to think that the more we advance the lower jaw or titrate the appliance, then the greater the benefit, what we call a linear dose response. I don't see that. I think a little bit of advancement is good and a little bit more is better, but you get to a point of inflection and then it gets worse. Their symptoms start to get worse. They will start to complain, if not about their teeth, that they're not feeling refreshed, that their snoring is worse. So I do not believe it's a linear dose response, and that's what also makes their job a bit harder. You've got to titrate these appliances, and you need very close communication with the patient over the first 4 months. There is no objective measure. We don't have a reader to tell us how good this is going. That's why we need a follow-up sleep study. We do have the potential for irreversible side effects, which I'll touch on in a minute. But we do have comparable effectiveness with CPAP. And that's another take-home point from tonight, is that whilst an oral appliance is not as efficacious as CPAP when it's on or in, if we combine efficacy with adherence, the patient using it, we know over a 5-year period, even less, that an oral appliance will probably have an equivalent effectiveness to CPAP. And that's why we're starting to use oral appliances used more and more and more for patients who have really struggled with CPAP. And that's really what I'm talking about there with effectiveness. That it's a different measure, and it's something that we probably should be really looking at. So effectiveness is weighing up more whole body experiences and life events and life health outcomes, as opposed to an AHI and an oxygen desaturation index and an ADIA oxygen. And this was borne out by Ferguson in 2006 when they realised that we should start doing sleep study or efficacy PSGs on all our patients. But really the mild cases would probably respond, and when we're saying we just use an arbitrary measure, AHI less than 10. If we've got that, that's a responder. So we know mild cases, probably 80% of those will get a good outcome, but there's still 20% who won't. Moderate, it's going to slide, and severe, it's dreadful. So what are the predictors? What are all these variables that make oral appliance therapy less predictable? So we understand if we're younger, we're going to get a better outcome. The females do better than males. And why is that? Progesterone. Until menopause, right? Because they have that stiffer upper airway. Also, how we distribute weight. Men tend to put their weight on around the neck, more so. Women don't put on weight. Is that right, Les? Right. And we also look at where that collapse is. We understand too, if the collapse is more lower, so tongue-based level, these patients are good responders to oral appliance. This is where the scope is important. We want physicians to scope the patient. And obviously the milder the apnea, the better it's going to be. But the Epworth sleep score is a very arbitrary measure. Not very, very good sensitivity and specificity when it comes to measuring sleep apnea. So whilst we can use the Epworth Sleepiness Score, don't read too much into it. Diagnostic information, well, basically what we understand, yeah, sure, the lower the AHI, these patients will respond. What we do look for, and what I look for in that sleep study, is what we call is supine-dependent or positional obstructive sleep apnea, meaning that supine AHI is at least 2 times greater than non-supine AHI. So you look at the supine and you look at the non-supine. And if the supine AHI is at least double, then you think, you know what, this might be a good case. But you'll find as the severity of the apnea increases, it doesn't matter whether they're on their back or on their side, the AHI is still up here. Whoops. This is more at a cephalometric level. And you know what? Whilst there's all these measures, what's the problems with Ceph? Is we're looking at patients in 2 dimensions. This is a 3-dimensional problem. And probably the reality is we probably should be looking at these patients with PA-KEFs, not VAC-KEFs, because it's the lateral dimension of the airway that's more significant. So I don't read too much into this, but one simple one that I do use is what we call the MPH and the PAS. The PAS basically is, if this one works.
Do you use CBCT?
Whoops.
McGaw?
Do I?
Cambridge.
Yeah, good. No. And why? Because it's not really going to change my approach. And it's a bit like using a LifeCare. Whilst a CBCT will show us the structures, it's not showing us what it's like when it's dynamic, and particularly it's not showing us what it's like when the patient is on their back asleep. And that's the problem with it. And there's a bit of radiation with it as well. There's a lot of studies that have shown that while CBC is a tool, the only radiographic requirement is an OPG. So it's really what matters is what we like on our back in rent sleep. And that's what a CBCT doesn't capture. These are little measures here that we can use basically to help guide us, but a very, very simple one is this measure here. So you can always have a LifeCare for the patient and eyeball it, but just draw a horizontal on the mandibular plane, perpendicular to the tip of hyoid, and if that's more than 19 mil, 18 mil, that's a bit of a red flag for me. Some people use 20 mil. And the other one here is the tip of hyoid, from the base of C3 across the minton. If tip of hyoid was below that red plane, that's also a red flag. These are not good candidates for oral appliances. Do I take LifeCares? No. Why? Because there's not a lot of evidence to justify it. OPG is the only film that's been supported for use, or ratified for use. Airway function. Probably what a lot of the sleep doctors do is they use the jaw thrust or the S-march manoeuvre to maintain the airway. And they literally push the jaw forward with the scope down their throat. And they like to see what sort of space they get. And most of them will do a jaw thrust. That's probably the most significant thing. We also understand too that the level of obstruction changes between Asiatics and non-Asiatics. So Asiatics will be more upstream because we have mid-face deficiencies, smaller top jaw, and Caucasians will be more lower level because we're more mandibular retrognathia. And of course, don't forget to look at their noses and try to look at their tonsils. Remember, the nose is the first thing I look at. You look at the symmetry of their nose and the collapse of the ala when they breathe. So now when it comes to the actual appliance, what are we going to make? Regardless of the name, we know it has to be custom made. We're going to be taking final impressions for this patient, and we're not going to just use some sort of generic off-the-shelf job and reline it. These appliances need to be minimum bulk. They need to be hard, not soft. And again, I'll show you a picture of this in a minute. The problem with the soft ones is whilst they might look better and whilst they might feel better in the mouth, they flex. So when we hold that lower jaw against the top, there's a reactive force against the top of the lower jaw. And fundamentally what it does is it will cause the appliance to distort within the mouth. And when that appliance distorts within the mouth, then we get orthodontic tooth movement. So we don't want minimum bulk appliances. These appliances need to be hard. Even the flex, the ones that have the hard outer crust and the soft inner sole, they're a pain in the butt as well, because the patient can compress into them. And they will when they brux, they'll still brux with these appliances in place, and this rubbery stuff will compress the teeth, and it will cause teeth to move. So we just want hard appliance, just like a plastic denture. And definitely nothing soft. It should be dual arch, so top and bottom, and ideally not joined or linked. So the patient can open their jaw without risk of disengaging either the top or the lower clutch. It's got to be titratable, or it's got to cover all the teeth too, that's important. You can't have any posterior teeth that aren't covered. It must cover all posterior teeth, even wisdom teeth, if they're there. And if you can't cover them, you get them out before you start. It must be titratable, and the finer the adjustment mechanism, the better. I use Sonident routinely. Why? Because it's the only one with a 0.1 mil adjustment. For some people, 0.25 mil is too much or too great. Lateral titration is better than anterior titration for two reasons. People with sleep disordered breathing, the mouth is their oyster, and the tongue is the king, it's the guardian, and the tongue does not like anything in the mouth. So if we have an anteriorly titrated appliance, the tongue will play with that. They get very, very sore on the tip and they hate them. So we use a laterally titrated appliance, and the other advantage of that is we find that we get less occlusal change with a laterally titrated appliance than an anteriorly titrated appliance. When we talk about traction and compression, well, basically it's just the mechanism. You know, have we got blocks opposing each other and pushing the jaw forward, or have I got straps? It doesn't matter, as long as we follow those rules. Have a little bit of lateral freedom so the patient can move their jaw. Don't lock them in. And I like plenty of room at the front, anterior breathing space. When it comes to the degree of advancement, really, some people probably put a lot of emphasis on the degree of advancement. So, how far can this patient advance? True. Some people say 5 mils. If I've got 8 and above, I'm pretty happy. 10 is good. 5, I'm just starting to wonder whether this patient's going to get a lot of benefit. They might if they're mild, but moderate, no, maybe not. So maybe again, just because I've got the prescription, it doesn't mean I make it. We notify the sleep doctor, not a good candidate doctor. And we stay away from the vertical. We understand the more we open these people up, it just rotates the jaw down and back and it impinges on your airway. It makes things worse. So this used to be used as a tool. Oh, the patient can only open 5 mil, but I can get them to open 6, and that's going to do better because I'm using a thing called a pharyngometer to measure their airway. So pharyngometry is a tool that's used to help titrate or work out your bite. Again, it has no evidence. Yes, Mark?
Regarding that open rotation of the mandible, are there any skeletal patterns which are contraindications for advancement splints for that?
Okay, good question. I haven't probably come across one yet. So long as they fulfil these requirements. Really, when you think of it, the patient with the small jaw, be it top or bottom, these are the patients who've got sleep disorder breathing. If we don't have that skeletal balance, that's where we've got the problem. And all we want to do is get the tongue base forward and away from the posterior wall of the airway. If we can achieve that, irrespective of the skeletal pattern, it doesn't matter.
Would it be less effective in a hyperdivergent pattern?
Yes, only because that's when you start to look at the relationship of your C3 to menton to hyoid bone. So, yeah, if I've got any doubt, I'll get a lab careful check that. But these are the patients too that usually are more severe, and generally these are the patients that you're not being referred for a sleep apnea device anyway. These are CPAP, they're more severe. You'll only be getting them as a salvage position. You understand? So most of the patients you'll be receiving will be the positional apnea cases, and these will be the patients that fall into these nice categories. But yes, no one appliance is any better than the other. There was a study that came out recently that talked about elastics, tying elastics from the top, bottom, lower appliance to the top, or having an engaging mechanism like a tap appliance at the front that engages with a hook, so that their jaws can't separate apart. Well, in this room, put your hands up. Who's got apnea? Anyone else? Right. Well, I'll tell you, if you wear an oral appliance, you'll still open your jaw, and if they're connected together, you'll pull the mother off the teeth. It's a pain in the butt. So whether you've got any engagement mechanism, you will still mouth breathe, and as you do so, you will pull the clutches off the teeth. And it's very annoying. So there was this study that came out that if we connected the two appliances, we got better outcomes for patients with positional apnea. I think that stands to reason by having these the clutches engaged more of the time through the night. That makes sense. We understand that the patient's apnea is going to be worse on their back than on their side. The jaw's going to drop back more so than when they're lateral. That makes sense. But probably in reality for these patients, what I'm trialling now is I use a headband. So just like a wetsuit, a headband. And the patient put me under this. And it's just like a scarf. They just put it on. And they go to bed at night. This lady did it to keep her hair together. But it's very, very good because it doesn't obtrude her ability to open, but it does maintain the jaw together most of the night. That was really the business about the opening. This was the study that was done in 2018 in the Journal of Dental Sleep Medicine. And like I said, whilst it sounds technically good, encouraging patients to have elastics on appliances, it's just one more thing they've got to do, it's one more thing they've got to lose, you've got to keep elastics. It's a pain in the butt, you don't need it. These things have got to be simple, and low maintenance. This was the Panthera, or the navel appliance, that you might read about. Panthera was made in Canada, and the navel was made in North America. And it looks great, it's thin, it's not bulky, but the problem with it, lots of dental change. It was a sintered vinyl appliance, not cheap, about $900 to get those made. I made one, I'll never make another one. The other problem with them too is being vinyl, we can't add to it. It's a dog to adjust. If you do any dentistry, you've got to refit these appliances, you can't. So, again, the American Association of Dental Sleep Medicine this year and have put out this summary, and that's a good little article to read. I don't know if anyone here gets the Journal of Dental Sleep Medicine. It's an article. It's a journal that often Ramesh will refer to, and it does provide some good, simple, useful articles. But I think it's really common sense. Don't need to go into that. That's just talking about the using effectiveness as a better measure of outcomes for oral appliance therapy as opposed to efficacy. And the person who did all the work in that was Peter Sestuli's group in Sydney in 2013, where they looked at severe cases, and they had a washout study on CPAP and then MAS, and they watched these patients over a period of time, and they found that the severe cases, in the scheme of things over time, there was no difference whether they're on PAP or MAS, and that's what we call the MAS-PAP study. It was a real turning point, and why we start to see now oral appliances used more for the more severe cases of sleep apnea. So when we start to examine these patients, what are the things we've got to look at? We've got to look first of all at jaw joints, range of movement, incisal relations, we've got to look at the bite, we've got to look at hard tissue health, we've got to look at gums. And we need to see, are they strong gaggers? And this is where sometimes I'll use a LifeCare for a CBT when it's debatable. So with jaw joints, and I'm not going to go into this in a lot of detail, but you need to be conversant with palpating jaw joints. You need to be conversant about asking patients about a history of locking or pain. You need to be conversant about having a ruler and doing a vertical measurement on every patient. I have a ruler on every bracket, and it's the first thing I do is I record that out. And if it's more than 35 mils, I'm fairly happy with that. If you're concerned, if you've got any doubt, get a CT of the jaw joint or an MRI. And a good rule of thumb there is 40 years of age. So under 40 we get an MRI. And why do we do that?
Soft tissue.
Good, eyes. Eyes. So under 40, a lot of CT near jaw joints, and the radiologists worry about eyes. After 40, that risk diminishes because most of you have got some degree of visual impairment anyway. So CT in patients for more than 40 and under 40, I'll use an MRI, unless there's any contraindication to MRI, like pregnancy, metal bits in their body, claustrophobia, things like that. Of course. So yeah, just very, very obvious things, but basically if this patient can open adequately, if this patient doesn't report any nasty pain or locking, then yeah, I don't have a problem with making an appliance, a Mandibular Advancements Splint, for patients who have some clicking. Even I don't have a problem for making a patient a Mandibular Advancements Splint if they've had arthritis in their jaw joints, so long as it is quiescent a la osteoarthrosis as opposed to osteoarthritis. So if there's any active arthropathy, that's a contraindication. If there's locking and there's pain, that's a contraindication. We need to manage those conditions first with conservative measures and then reassess an oral appliance. We do know, lots of studies have come through, that long-term use of an oral appliance does not otherwise cause impairment to the temporomandibular joint. Lots of studies now demonstrate that. Where the problems arose was the appliances were being made for the wrong patients. A lot of these patients did have active arthropathy, and it wasn't being assessed and managed early or detected.
So if your opening is less than 35 or 30, your routine treatment is physio treatment?
I would investigate, so I get a diagnosis, I get a scan of the joint and see if there's any arthropathy or any problems. And then if I've got any concern, then I might instigate, yes, non-invasive therapy, so it might be splint therapy, physiotherapy. And if the patient does have apnea, if it's mild, it's not so bad. If it's moderate to severe, that patient might be a better candidate for CPAP. And if they're good on a CPAP, then I could consider a splint. I'm not going to make them a splint until they're compliant on the CPAP. And if it is a splint, it's a lower splint, not a top. Preferably hard acrylic, not full coverage polycarbonate. A bit like what I did on that splint tool. Okay? But we don't make splints, and that's a good point, until they're medically managed. Alright? We can certainly use physio, so physiotherapy is a good tool. We've got Lee Ray here, who does a lot of physio for TMD. So physio is a very useful tool. We can apply physical therapies, and just with CPAP. Once they're compliant on CPAP, then if they're going well with CPAP, stay on CPAP. Sometimes their TMD settles down. Good. Don't make them anything. I've still got a few problems. Okay, we'll make you a mandibular splint. Are you happy with CPAP? Yes, I am. Let's make a mandibular splint. Or, no, I'm not, but their opening's improved, their discomfort's settled down. I definitely want a mass. Then reassess. The occlusal type, really, you just got to have enough teeth and watch out for the tori. Most of these patients will have lots of tori because of clenching and grinding. But they don't get in our way when we make appliances because we're not sort of extending too much into the soft tissues. And this is where I always get study models. So I will not use stock trays for a mass. I will always use special trays. And the reason for that is I like some study models to look at the angulation of the teeth. So most of these patients with mouth breathing, their tongue has dropped back, the lips have shaken over, and normally the top teeth lean in and the bottom teeth lean in. And what's the problem with that? Appliance retention. Where am I going to get my retention? So what do as I survey it. I pull out my little survey and I have a look. Where are the undercuts? And then I communicate this with the lab. If I've got real concerns, sometimes, but I've only done it once or twice, I use a flex design. But normally you can compensate by placing clasps lingually, not buccally. Right? But you've got to communicate this with the lab. How many teeth do we need? Really, again, common sense here. You just need, it's like a denture. You just need enough to hold the thing and to offset the reactive force of the appliance. So to me, a rule of thumb is either like 4 solid teeth in the lower jaw as a minimum, opposing an edentulous or a partially edentulous upper arch. But ideally, they work on 6 to 8 teeth. 6 to 8 teeth is good. And obviously, if they've got periodontal disease, well, we need to make up for that by adding a few more teeth. The worse the gums, and a lot of these patients have gum disease. Why? Because of the mouth breathing and the systemic inflammation associated with the apnea. So most of these patients also have some level of periodontal complication. The OPG is mandatory. We need that as a requirement. Obviously, if there's any decay, any problems, that's got to be sorted out. We might see fluoride bombs in these patients because of bruxism. So we screen, just the basic things that we do. And if need be, in many cases, we just get the urgent dentistry done and get them into their mass. And then once they're stable on their mass, we can come back and pick up the teeth. This was the call here, Vincenzo, about the hyperdivergency. So if we have a mandibular plane, a horizontal dimension of more than 25 mil, that's a red flag. The posterior airspace is measured on the lap kick, just the back of the tongue to the back wall of the airway. If that's less than 5 mil, that's a red flag, and if I've got increased lower facial height, that's a red flag. They're generally patients that I don't want to be making mandibular advancement splint. Some people would say, oh, let's now make a tongue retaining device. Well, I don't know how many pictures you've seen of a tongue retaining device. I don't think I'd make one. They don't look pretty. I don't imagine they're overly comfortable. But some people do have to use them. Contraindications. There's not many contraindications to using these appliances overall. Probably the average patient, maybe 20% of cases would be contraindicated if you wanted to be a purist. But for most patients, we can generally get by and make an appliance if we think about it. What are the complications? Short-term and long-term. Salivation is always the worst one. These patients will dribble a lot to start with. It's really annoying. Really annoying. They make a lot of saliva, but it does get better. Sure, they'll complain a little bit about dental discomfort. They might complain a bit about transient bite change. Their jaws get a little bit tender. So what do? We don't toss them in and say, hey, you've got to wear this 5 nights a week starting now. We graduate them in. So it might be alternate nights for a week. It might be a couple of nights and a night off, a couple of nights and a couple of nights off for a month. And then I tell them by week 6, I want them up to 5 nights awake with them. And I also start generally at around about 50% on my protrusion bite. I don't start them off at 60 or 70. And when I talk about the records at the next visit, taking records and the clinical aspects, I'll talk about the actual measurements and where I start at with the appliance. But in simple term, you need enough meat within the adjustment of the appliance to cover the full protrusive range of the patient. So a Somnodent would have 5.5 mil of protrusive range when you get it. So I'm going to make sure that that will cover the full remaining protrusive range for that patient. So if they've got a protrusive range of 10 mil, I'm happy to start them off at 50%. Because the remaining 5 mil, I've got to play within my appliance. Do you understand? If I've got a patient with a protrusive mil of 14, I might start them off at 60%. Because that remaining 5 mil that I've got to play with will probably get me to 90% protrusion. You'll probably never use it anyway. This is where you'll see different designs, like the Somnodent Fusion, where I've got these detachable wings that I can step it up and step it up. It's just another layer of complexity. It's another thing they'll lose. It's another thing that will break. You know, you can always add a little bit of acrylic to the back of a wing. Take a few turns off to compensate and away you go again. In the long term, yes, we will get bite change. Tell them that. You are going to get bite change and it is irreversible. Full stop. Do people care? I've got bite change. Does it worry me? No. It's only there if I really think about it. Sometimes patients get a bit of food packing at the back. But probably the biggest one would be what I call appliance disengagement. So this is a case here of a patient who's worn a sleep apnea device for around about 6 years. And he went to his dentist. It wasn't a case that I had treated. He went to his dentist and said, that's appalling. You've got to stop wearing that straight away. So the patient stopped wearing that straight away, but of course now he's having no treatment. And this patient was a heavy machinery operator in a mine up north. And he had moderate to severe apnea. So that wasn't the best advice. The best advice would have been, hey, we do have some bite change here. I'm a little bit concerned about that. You know, maybe what we should do is communicate with your doctor. When was the last time you had a sleep study? 5 years ago. You know what? Let's get a review sleep study and see where we're at. You might not even have apnea now. You might not need to wear an appliance anymore. Or you might not need to wear an appliance 5 nights a week. But just don't tell a patient to discontinue. We are not licensed to do that. The doctors are licensed to do that. We must communicate this with the doctor, their GP, as the first port of call. This study here by Branches has come out this year. No significant change in tooth position during the first 2 to 3 years of test period, so long as a prosomnus is a hard acrylic appliance. Laterally titrated, nothing soft, nothing flexible. And if it's locked together, things don't move. So a rigid oral appliance made using CAD/CAM technology. You don't get many problems with these appliances. This was a case I saw. A patient came in and woke up with this in his mouth. How lucky are we? Huh? So we need to think about the limitations of what we do. We're not meant to wear these appliances. And there are risks associated with wearing it. This can dislodge. It could end up in our throat. It could worse end up in our lung or our tummy or our bowel. But what are the implications of that? Who is responsible for that? We need to warn patients of this before we start. This is a limitation with using cheap Mandibular Advancements Splints. I don't use them. I use Somnodent, and I tell patients, you know what? The lab fees are sometimes double what I would pay with maybe a generic lab. Why do I use it? because I get very few problems. They're stronger than my robust, and they stand by their product, 3-year warranty. This is another classic that I saw. Now this is an appliance made by a Perth specialist. And this appliance was originally set at around about 50%. It is similar in a way to a Somnodent. It's laterally titrated. Basically, the adjustment mechanism is on the lower clutch against blocks on the top. So the blocks on the top are stationary, and we've got these adjustment rams downstairs. So he came in, he was sent to me by the sleep physician saying, please make him a new Mandibular Advancements Splint. His old one is no longer working. He doesn't feel benefit from it anymore. He had a review sleep study because the doctor thought his apnea might have got worse. His apnea had actually got better because he'd lost weight. And I didn't understand this because he'd had this appliance for 7 years. So what I did is I wound it back, right back to home, and I had a look at it. And it seemed to be engaging the blocks quite well. Then, when we titrated out to where he came into me with it, he titrated it out 5 mil. It was around about 80%. We can see here that the block on the right-hand side is disengaged. And he was also complaining about jaw joint problems. So you need to be confident that when you advance these blocks are going to engage with the wing. You've got to look at the geometry of it. So there's a lot of science to the design of these appliances. The blocks have to be a certain width to cater for the advancement of the lower jaw, and the wings or the engagement mechanism on the lower arm need to maintain their contact with the blocks. So what do? I'm just making a new appliance. I'm making the Somnodent, but you can see here that's why I was getting a sore jaw, and it was just dropping back. So he just come off the rails. So in summary, the severity of the complications will be really to do with the degree of the advancement. Obviously, the more we advance, the greater the protractive force and the reactive force, and the greater the problem. So the less we've got to advance these appliances, the better. We don't have to take everyone to 70%. Some people can be very, very good at 50% or 60%. And if they've got some T&D, start them off at 30%. Something is better maybe than nothing. We need to be mindful of the design. We need to be mindful of the teeth that we're making it on. And also, the good thing with Somnodent is they provide a deprogram with their appliance. And I'll talk about this in a subsequent lecture on the clinical delivery. Informed consent is absolutely vital. We must have this in writing. It must summarise the indications for the appliance. It must advise patients that there is no one appliance any better than the other. Patients have to understand that they've got to acclimatise and get used to before we titrate, and it's going to take some time. The response is not predictable. I can't tell you that you're going to get a really good outcome or not until we have that follow-up sleep study. And a follow-up sleep study is essential. And if there is any upstream resistance, and if you have problems with your oral appliance, then as a fallback position, it might be wise to consider a nasal assessment, particularly if the sleep doctor has touched on that. And you keep all copies of your correspondence. Clinical notes are so important with this. There's my one-pager that I give to patients on oral appliance therapy. That's just their informed consent sheet. So then, once I've done that, and I deem the patient as a candidate for a MAS, and the patient's been given all the information, then I've got to write to their general medical practitioner, or first of all the referring sleep physician. He's got to be informed that I've seen the patient and the patient is going to proceed. And there's no contraindication from my end. I've got to send a copy of that to their GP, I've got to send a copy of that to their dentist, if they know them, but some patients don't always know their dentist. And I always send a copy of any correspondence to the patient. At least then the patient can't say, you never told me that. You keep everything in writing and have really, really good notes. And that I can't emphasise enough. Very important. So that completes this lecture, and this is the longer part. The The subsequent lecture next month, I'm not too sure what date it is, but I think it's 4 weeks. It's probably only about 40 minutes. It's shorter, and there'll be scope here for questions. So that's just more on the clinical aspect, the sequence I take with my records, the impression techniques that I use, the bite technique that I use, the communication with the lab, the titration, how I explain that to the patient, then the follow-ups that I have. I have 2 follow-ups with the patient over 4 months, and then the final communication back to notify the sleep doctor. And then your awful bottle on mandibular advancement splints. Is there anyone in this room who does mandibular advancement splints or has an interest in it or not? Yeah, Sam and Alex. Okay, that's good. Yeah. Okay. Any questions? Clear as mud? There you are.
Times today where some of the newer graduates say, here's an occlusal splint, see you later, I'll see you in 6 months for your normal recall. And so Tim is actually just giving you a little bit of an insight that same with your MAS, there's more to it than just here's your MAS and I'll see you in 6 months. But thanks very much, Tim, and 4 weeks. Thank you.
Thank you for coming.